Great. Welcome, everyone. Thank you for joining PEPI, Project Echo for Primary Immune Disorders. This is the third of a three-part series conducted by Jacob Blokovich, who's a PhD student in Virginia Tech's Translational Medicine, Biology, and Health program, where he's focused on really educating the community about rural health disparities in general, which was part one, rural health disparities among allergic and immunologic patients, which was part two, and then part three, focusing more on rural health disparities in the clinical immunology domain. So we're grateful that you're here. As you are joining, please feel free to post your name if you haven't joined us before and where you're from. And of course, we'll also be supplying our YouTube site and our website in the chat. With that, I'll turn it over to Jacob. And Jacob, thank you so much.
All right. Thank you for the introduction, Dr. Ryder. It is a pleasure to be back here again. Let's get this up. So for my third presentation, like you said, I'll be focusing more on clinical immunology and primary immune deficiency specifically. So it'll be, what do we know about the impact of having a PI or primary immune disorder and living in rural America? So here's my PubMed search looking at that specifically. This is a decent PubMed search, kind of looking through all of the different names for a PI, rural in the United States, and looking at health disparities. And if you can see that big fat zero on the right side, that's pretty much how much we know about rural primary immune disorder health disparities. Not a whole lot, if anything. So that's all I've got. Thanks for coming. But actually, just kidding. I will talk about some more stuff. But as usual, I'll start off by defining, what rurality is in general. So we'll look at metropolitan or urban areas, which are core counties with one or more urban areas, including nearby counties with commuters over 25%. Micropolitan is kind of your larger rural areas that have an urban area with over 10,000 individuals, but they're either not as large as the metropolitan areas or they're not as numerous. And then non-core are your non-metropolitan or rural counties that don't meet those specifications. So smaller areas don't have urban areas at all, things like that. And you can see the US map from the Rural Health Information Hub on the right side of the screen here. And you can notice how the vast majority of the United States is that dark blue micropolitan or non-core rural area as far as the landmass goes. It's about 97%, and a little under 20% of those individuals as far as the US population live in those rural areas. So even though we don't know anything specifically about PI, we do know some stuff where we can infer some disparities. So things like the distribution of allergy and immunology providers who would be treating those patients, for example. This was a study based on census data from 2012, and you can see across the board throughout the United States, there's about one allergy immunology physician per 100,000 people. You can see up in the Northeast, we almost get to two per 100,000, but still not quite there. So obviously, just in general, there's a disparity in a lack of providers across the board, and obviously that's typically worse in rural areas as they're generally more centered in urban areas, which we can kind of see in this next map, as you can see more specifically by county where those individuals are centered. You see a lot of them over on the West Coast and up in the Northeast. And apparently, allergy immunology providers really like Florida, so there's a lot of them down there as well. But once again, we can kind of see throughout the middle of the United States and down here in the Southeast, there's a lot of gaps as far as locations for those individuals. And this is a map which was prepared by Tia Parrish, one of our lab mates up at the Jeffrey Modell Foundation. And this is looking specifically at the primary immune disorder experts as defined through the JMF, who is an international nonprofit organization that works with primary immune deficiency patients. And those are the individuals who have kind of filled out their survey and given them data and said, we are people that you can send patients to. And you can see once again, kind of concentrated on the West Coast, some in Texas and throughout the Northeast, but obviously some large gaps throughout the central mass of the United States where a lot of that dark blue rural area was present. And then another thing we can look at is genetic and genomic testing, as most PI diagnoses are confirmed by that genetic testing, since it is a heritable mutation and there's about 500 different ones. And And access to those can kind of be spotty in rural areas as well. This is a graph looking at awareness of genetic testing in general, stratified by racial and ethnic groups. And you can see that in these blue bar graphs, it is generally, 5 to 8% lower in rural areas compared to urban areas as far as awareness in general. Although across the board, it's not great for awareness anyway, considering even the highest category in the urban area is not even 45% as far as awareness goes. And moving from there, this is, kind of diving further into that of things that are, leading to issues in these genetic and genomic testing things, either allowing them or a barrier. So you can see lack of awareness again, just lack of infrastructure, distribution of the workforce, as well as what the culture in the rural areas is. Either they are used to not having these kind of services, so they kind of just do without, or it's not something that they really are interested in dealing with. So it's essentially saying, we need to grow the workforce. We need additional places that can do these kinds of testing, and we need to educate and improve health literacy in these areas to, really let them know why this is important and allow them to have access to these kind of things that can help with the diagnosis of PI. And then this was a study looking at rural versus urban factors contributing to direct to consumer genetic testing. So this isn't something they'd have to go to a clinic for. This is something that's just getting sent straight to them and they send back. And you can see that as far as geographic location, the rural areas are less likely to know that, as well as individuals who are older and of minority status. And then the second half of that figure, you can see that the individuals who are less educated and who are more impoverished are less likely to have awareness and access to that genetic and genomic testing. So that's kind of the same theme that we've seen across the board in these presentations, is that the individuals in rural areas are generally less educated, more impoverished. A lot of them are older, and it kind of just leads to lower levels of health literacy, lower levels of access to care. And we see that reflected here as well. And then again, looking at infusion and home infusion, as a lot of individuals with PIs get treated primarily by infusion of IgG most of the time, or analogs or other treatments, which are often requiring infusion centers or, in some cases, home infusion as well. This was a study that looked at the rural pediatric irritable bowel disease and Crohn's disease population, looking at infusion centers that these patients were attending. And you can see that for the most part, about 70% of those individuals are driving at least a half hour to get to an infusion center, though still about a third of them are driving at least an hour to 2 hours to get to an infusion center to receive treatment. And about 59% of those individuals had to reschedule their appointment at least one time during the study. And this, a lot of the times, was due to school for the kids, work for the parents, just a cost in general, or health from associated chronic conditions or from side effects, etc. So we were seeing a lot across the board with some issues interfering with that specifically for these areas. It's kind of hard to get your kid to an appointment if it's, 2 hours away there and back, and, you still have to work. So obviously that can interfere with those kinds of things, which leads to home infusion. This was a study looking at rural versus urban home infusion percentages. And you can see kind of across the board here, the rural is substantially lower, though it does appear to be rising somewhat. Some of this could be due to the fact that they're not as close to health centers and may not be as comfortable doing these kind of home infusions in case there's an adverse reaction and, say they are 2 hours away from the nearest treatment center. Additionally, health literacy and things are lower in these areas, making them less likely to take part in these services as well. And we'll talk a little bit about some other specialties that are similar to allergy and immunology and PI, but not exactly the same, and kind of infer some of the barriers that they have in those specialties to talk to PI as well, since we don't have anything PI specific at this point. So just to start, this is looking at pediatric rheumatology. This was a study with the pediatric rheumatologist physicians and what barriers they saw to care for their patients. Primarily, availability was the biggest thing. There weren't any clinics nearby, or there weren't any spots for those patients to get in. About 95% of the doctors said that was the biggest problem. There was also some evidence in the study showing that the majority of these individuals had to go to pediatric rheumatologists who were over 50 miles away from where they lived. And this was a study specifically looking at lupus, which is another autoimmune disease, which can sometimes be compared to PI. The overall prevalence you can see here is about 72.8 per 100,000, which is somewhat comparable to primary immune disease, as Dr. Ryder previously established in a study. It's about 60 per 100,000. Though you can see it does differ drastically by gender and ethnicity, as you can see in the AIAN population, for example. It's about 270 per 100,000 for those women. It does appear to be lower for men, kind of across the board here, which is kind of leading to where we're seeing that more middling prevalence, even though it may be a little bit different than we see there. And then this is a study looking at rural disparities in demographics associated with lupus. As you can see, for a similarly prevalent disease, they've been doing rural research since at least 2012. So obviously a gap in PI there, since that's something that we haven't done for there. But you can see this is more common in the mestizo kind of Latin American population there, generally more common in individuals who are less educated and with lower socioeconomic status, as well as less access to insurance. And you're seeing higher proportions of that throughout the rural population here, seeing as, about 82% of that rural population in this study was considered to have low socioeconomic status, and then less than high school education for about 42.6. So obviously some substantial gaps there that are leading to some of these disparities that we see. And then this was looking at hematology, another somewhat similar specialty. This was a study looking at hematology mortality and where the individuals died as far as it went. So you can see that for rural areas, it was much more common either at home or in a nursing facility, though in your more metropolitan or urban areas, it was more common in a medical facility or hospice care. Especially for hospice care, you can see that rural is substantially lower than both categories of metro. So obviously a place that would be interesting to look, is there less access, or is it a cultural thing of this is just something that they're not interested in or not used to? And generally there's more of a family environment in rural areas, so that may be part of why you see more of them just staying at home for a lot of these things as well. Moving to oncology. This was a study looking at urban and rural area of residence in concordance with some quality metrics by cancer type. So you can see that in the rural areas, based on the odds ratio, there were some areas of treatment that they were less likely to receive kind of the optimal care as judged by those guidelines in California. So for breast cancer, you can see that they were less likely to receive that radiation after lumpectomy. For colon cancer, you can see that they were less likely to receive the most optimal surgery, is how the study worded it, essentially. Some of that, once again, could be due to lack of access to the tools or facilities to be able to perform, these state-of-the-art, more technical surgeries. Some of it could be due to, just health literacy of patients. They just want the least surgery or the least treatment or whatever they may receive a lot of the time. And then another study, this was looking at rural and urban cancer mortality across the board here based on different definitions of rural. Though across the board, you can see that it was about 15 to 17% higher for rural mortality versus urban. And you can see this was especially true for screening-related causes. So that's obviously an area of further intervention and policy that's needed. I know that's something that's been worked on a lot as far as colon cancer screening and things like that go for rural areas. But clearly, we still have some more work to do in that area. And then dermatology. This is a pediatric dermatology physician density study. You can see that pediatric dermatologists are almost all in urban areas at 96.4%, with only 3.6% of them practicing in rural areas. So obviously a huge gap there for anyone who has that sort of treatment going on. And this was just dermatologists in general looking at physician density by specialty and year. You can see that about 4.1 per 100,000 in metropolitan or urban areas compared to a little bit over 1 for your non-metropolitan/rural areas. And across the board, the reason we kind of looked at these other specialties is a lot of the times PI patients have treatments from a variety of different providers. It's kind of a collaborative effort of you have individuals, they might have dermatologists checking in with the allergists and immunologists, they might have rheumatology, or it might just be the closest type of advanced or subspecialist that they have nearby. They might not have access to an allergist or immunologist, so they might have to go to a rheumatologist, or this might just be something that their primary care provider has to manage. Across the board, throughout this series, we've kind of seen a lot of the same things as far as rural disparities go. We've seen a lot of socioeconomic status being a problem. There's a lot of education and health literacy problems, and there's a lot of kind of just aging populations, access to healthcare, and lack of insurance. Obviously, all of those are hard to deal with on their own, but are certainly important to consider as we move forward. And obviously, since we don't really have any specific PI health disparities research for rural health areas, that's something we need to work on in the future. But that's all I've got for today. So does anyone have any questions? You can either ask them now or my email's at the bottom if you're interested.
Jacob, thanks so much for this great talk. I'll just kick us off and hopefully give time for others to think about questions they might have. I think as PEPI, we're intensely focused on understanding the drivers of disparity for patients with immunologic disease in rural spaces, whether they live in the US or otherwise. But of course, we're focused on the US because this is where we are. But we're also broadly focused on just optimizing diagnosis and care for PI patients, regardless of where they live. And I think a couple of themes that you brought up are really important. One is that a clinical immunologist could come from an allergy immunology background, rheumatology, infectious disease, hematology, oncology. What's important is the interest in and the expertise around these patients, and not so much necessarily, within which specialty they trained. We're grateful as members of PEPI to connect with any generalist or specialist who has an interest in advancing care for these patients. But I think what you brought up, which is really important, is that if the system is broken in general, whether it's urban or rural, it's certainly not going to work for anyone, but it's probably going to work even worse for people with a rare or complicated disease. And I think you underscored the fact that access is one issue. So like diagnosis. And then the other issue is supporting patients who have a known diagnosis and giving them the care that they need and deserve close to home, which is also central to the ECHO model mission. So kind of with that background, did you see any ways or solutions that arose from any of the other specialties or the other patient groups that you looked at around, in particular, supporting patients to build a capacity that where the diagnosis is known, for example, cancers or lupus, some of which actually may include some of those studies may include PI patients. But I was curious if you came across anything that we could learn from.
Um, as far as that goes, there were some models that kind of introduced like satellite clinics where they had little mobile clinics or just smaller facilities where they were able to go see more of these patients that they weren't able to otherwise see. A lot of it also is kind of telemedicine or echo type models where they're reaching patients virtually. But as we talked about in the first presentation, a lot of the times you're still missing a substantial chunk of those patients who don't have virtual access. And like I mentioned last time, community health workers are often implemented. There's generally some models of care that you see a lot in cancer centers where there's a lot of different kinds of support for patients that could be beneficial to incorporate more into other care models where it's more they have like a social worker on staff, they have a community health worker there, they have some practice facilitation and nurse navigators, and they have kind of just a broader group that's able to reach more of these patients and facilitate things like transportation and food and housing and more of these things that a lot of those patients struggle with. So maybe more of an integrated care model could be a place to try to move forward to in the future. Though, as you mentioned, when it's kind of a system or a systematic thing, it's hard to change that in general, especially on like an individual small rural clinic basis.
Thanks for that. Very helpful. Any other questions, thoughts, ideas? Well, as always, oh, okay. Yes, thank you. There's a survey posted. Thank you, Angie, for posting that. Please check out that survey link. We covet your feedback. We really want to grow Peppy. We're about 6 months old now. We're very, very grateful for everyone who's attended and contributed. We're going to continue to put more content out there, and we have a number of both quality improvement, public health, and research aims that we're going to be approaching in the coming months. So continue to drive this forward. So in addition to the survey, please tell your colleagues, tell your neighboring practices about us. Please spread the word, help us spread the word. We want to be a resource for both an educational front, which is what these sessions are all about. And of course, as Angie has shared, these get posted to our YouTube site. So they're there as enduring materials for anyone in the world to see whenever they have time. And they're intended to be bite-sized nuggets of information just to stimulate discussion, show gaps that need to be closed to advance care for patients. But the other arm of our PEPI program is really providing free subspecialty consultation to clinicians at this point in rural America who would be potentially evaluating patients that they think may have PI. So we want to be a resource, a point of contact for those individuals, not only to give free expert consultation about diagnosis and management of these patients, but also to help point those clinicians and their patients to colleagues that we know through our own network of subspecialty clinical immunologists, which again could come from within the specialties, allergy, immunology, infectious disease, rheumatology, hematology, oncology, and so forth. So thank you all so much for your time. Please reach out to us. And with that, we'll close the session. Have a wonderful day.